Okay, good afternoon. My name is Blaine Johnson from the University of Chicago, and I'm really excited to be a part of today's transplant and NCS session. It's a big honor to follow Dr. Lore and Sanjay, who are experts in their field. Today, I'm going to share with you some new and exciting developments in donations and where I believe the future of organ perfusion or the organ perfusionist is headed. So I have no disclosures or financial conflicts. I am a practicing perfusionist, and I believe that we should be involved in organ recovery. Today, in the interest of time, I'm going to keep this kind of surface level, but I do suggest you go back and find the different primary literature that we have listed at the bottom for your review. So let's look at the state of organ transplantation, right? In 2022, it resulted in more organ transplants than ever before, despite the ongoing challenges from the COVID-19 pandemic. While transplantation continues to increase in stability, we continue to explore the improvements that we need to increase utilization, but to also maintain organ quality. And today we're going to explore some of those current advances to increase utilization. Let's look at the acute shortages in donation. Several factors limit the current organ supply. Those include legal, clinical, and systematic barriers to utilization. Now, the most cost-effective treatment for organ failure is, of course, transplantation. One way we can expand the donor pool is to simply address the massive underutilization. Now, what's interesting is this is a 2020 data. So if we compare that to the 2021 data, you actually see a 10% increase in US donors and also a 13% increase in utilization of hearts and lungs, and a 25% increase in underutilization of livers. So remember, every organ wasted is a life not saved. But what's interesting is transplantation is a supply constrained market, right? If we further analyze that, we can see that it's primarily due to limitations in cold storage and preservation, in addition to the lack of donors. So let's head down a deep dive and see what else we can do. First, we need to understand the difference between donation after brain death and donation after cardiac death. What's interesting is the first transplant in 1967 was actually performed using a DCD heart. But DCD heart transplantation fell out of favor as brain death criteria was better established. What's interesting is the first resurgence appeared around 2008, where they had reports of successful pediatric DCD heart transplantation in Denver. So in this model, you'll see the differences between a controlled and a non-controlled DCD donation. An uncontrolled is on the left where we have no flow. We wait a certain amount of time. Maybe there's a CPR duration, and then there's a no-touch period, and then you start your organ preservation. Now, this is compared in contrast with the controlled DCD that we're going to talk about here in a little bit on the right, where that functional warm ischemic time starts when you see a sensation of blood pressure, and that allows us to have a greater amount of time for the organs. So DCD recipients and donors, it's really important that we also look at the differences between the two, right? It appeared that the outcome for DCD hearts are equivalent in research when matched with DVD donors, despite the period of warm ischemia. DCD donation can be done using several different models that include normal thermic regional perfusion or direct procurement and reperfusion. So let's dive down into normal thermic regional perfusion. NRP adds a powerful tool to organ recovery. However, it will complicate an already imperfect process. Here we explore Vanderbilt's approach to doing NRP. And you'll see that what you start with is a standard DCD withdrawal, declaration of death, and a standoff time. But after that, things quickly, progress. We have a sternotomy and a pericardotomy. The biggest change here is that we're going to clamp the head vessels. And that's so that we, get away from the ethics of saying that there's reperfusion to the brain, that's what in this case we don't want. Then after that, we initiate circulatory support. Eventually, we end up venting the pulmonary artery. We're going to assess the cardiac function, which in Vanderbilt's case, they call it the eyeball test, which is a little bit different than other models that use more of a quantitative measure. And then you recover the organ in usual fashion using a cross clamp, an infusion of cold crystalloid preservation solution. In this case, Vanderbilt prefers Del Nino, and a standard cardiectomy. Now, what's interesting is the leaders who pioneered NRP in the United Kingdom and Europe was the landmark series done by the Papworth Group. And what's interesting is when they published their 5-year data, they compared the difference between machine perfusion and normal thermic regional perfusion by itself. And their study found that they examined long-term outcomes and incidence of primary graft failure, and that with ECMO and NRP, they did see at least a equivalence. But these don't come without risks, right? Here you can see the overall risk and benefits to NRP. We have risk of primary graft dysfunction, which is actually no different than brain death donors that we find. There's obviously ethical concerns that we talked about, such as the Lazarus effect and reanimation of the patient. But having those, techniques and established protocols within the OPO and the different institutions are really important to how we can address those concerns. And DCD protocols may vary between hospitals, but again, that's why we're working towards more standardization as we learn more about these processes and techniques. What's interesting though is, we look at the cold storage limitations, like I said. We have cold ischemia. There's no, like Dr. Lohr said, no ability to assess the organ, and also we have a lack of optimization. So an interesting innovation that we can do is kind of give it a Fitbit or an Apple Watch, right? But we can also keep it warm and perfused and ventilating, for instance, in the example of lungs, so that we can provide warm blood perfusion. We can have organ assessment, and we can also have therapeutic intervention and optimization as well. So let's look at ex vivo organ perfusion. Right now, there are 3 companies that are really leading the forefront in ex vivo organ perfusion within the United States. We have the Transmedics-based, Massachusetts-based Transmedics, which offers the organ care system for heart, lung, and liver that Dr. Lohr talked about a little before. We have Organox, which is a UK-based company who has Meta, but that's more for the abdominal and liver teams. And then we also have Ex Vivo, who's Swedish headquartered, and they offer the XPS, Ex Vivo lung perfusion, again, that Dr. Lohr mentioned. And they're also in clinical trials in Europe and Canada to offer their heart system. What's interesting is the 4th party listed there is Lung Bioengineering, again, that Dr. Lohr talked about. What they do is they utilize Ex Vivo's organ perfusion module in a stationary model, and then they provide regional services to maintain those marginal organs. Again, we look at Transmedics, who's the only FDA-approved multi-organ technology out there. What's great about these platforms are they include detachable wheels, a lightweight construction base, and integrated power and gas supply that really allows us to go wherever we need to get those organs that are optimized for the patients themselves. Now, if we look at the clinical impacts, you'll see again for both heart, lung, and liver, some great outcomes when compared to the standard of care today, which is static organ preservation. And you'll see a 91% patient survival at 1 year, for instance. But again, OCS is great, or ex vivo organ perfusion, because it allows us to push those historical boundaries. The colleagues at Duke present a case of a 41-year-old female who was able to get a bilateral lung transplant with a set of donor lungs all the way from Hawaii to Raleigh, North Carolina. And this patient at 1 year had experienced no primary graft dysfunction, and she remained rejection-free and had excellent pulmonary function at the time of follow-up. So it really shows you, like Dr. Lohr said, we're now pushing the boundaries of what we thought was possible with 20 plus hours of machine perfusion with great outcomes. Let's look at some other modalities as well, such as extended criteria donors. Dr. Lohr talked about the EXPAND trials for lung, but of course we should also dive down into the EXPAND trials for heart as well. We see significantly improved utilization of DBD and DCD lungs and hearts that have been declined for transplant. This is the highest reported utilization of these donors for transplants. And, Dr. Lohr showed the different categories that included older donors, DCD donors, higher ischemic time, and even, some PF ratios that are a little under what we normally would use. So there's also other modalities within the extended donor criteria that we can look at as well. That includes, for instance, for cardiac and other organs, hepatitis C virus, right? So a big game changer in the last decade was the discovery of direct acting antiviral drugs. And we're seeing cure rates of 93% or higher with these acute and chronic HCV. So now, when we approach these donors, we should, of course, tell them of the risks and benefits. But if you do have experience with this and you have financial backing, it's, a great way to extend the donor period. We can also look at a study there from St. Vincent's in Indiana of 25 Hep C transplants for heart transplant. Their mean waiting time was 3 to 45 days. They did have serum conversion, but they exhibited an overall 100% survival with no difference in rejection, hospitalization, or death when compared to patients without donors at high risk of that. Another interesting, thought is that we can expand the donor pool by using COVID-19 positive patients. Both HCV positive and COVID positive hearts and other organs will substantially increase the number of donors available. We see two studies here on the right. We see a small study of 12 hearts and 2 lungs that exhibited no transmission to the recipient, the healthcare workers, and had great survival and graft patient survival outcomes. What's interesting is then we see a meta-analysis as well there on the right that shows all the different organs with their outcomes as well. And, with COVID-19 positive donors, I think they are safe and effective. But of course, with lungs, we still have to continue to monitor as well. So if you were around last year in January, you saw some really exciting things in the field of xenotransplantation and regenerative medicine. Dr. Lohr talked about, the different things that they're doing here with lungs. And I'm going to talk about a little bit more in the cardiac section. These modalities allow us, could be targeted towards potential future recipients, such as contraindications for MCS, patients who have high PRAs, chronic cardiac allograft rejections, or even, children with congenital heart disease. This allows us to expand those donors in these modalities. So let's look at the concept from, concept to the clinic. Recent compassionate use transplant, like I said, for a genetically modified pig with 10 modifications listed there on the right, that included 4 knockouts and 6 knocks-ins into a terminally ill patient who survived over 2 months. Adequate regulatory and ethical frameworks obviously are very important, as well as, like we talked about, stringent criteria for selections of patients. And that'll be critical moving forward in the development of cardiac xenotransplantation. But what's really interesting is there's actually been roughly 10 different clinical xenotransplant ever in the world. The first was in 1964 with a chimp, Another big one was followed in 1984, again, with Bailey and the chimp. And then, of course, the one we just talked about with the first short-term success wasn't until January 2020, and the patient lasted for 60 days. Following that, researchers at NYU Langone decided to also do further studies for transplants in 2 brain death patients who were not eligible for organ donation. And they, provided them xenotransplants to see what the outcomes were at 72 hours. And again, really promising outcomes there. Now, this is a groundbreaking approach to increasing organ supply, but there are, like we said, as you saw in January 2020, issues of transmission of zoonotic diseases from animals, and we need to further analyze that data. What about bioengineered hearts from recipient tissue? There's several topics of interest here around anatomical scaffolding, decellularization, and recellularization. If you've been around the Heart Institute for the last 5 years or so, you've heard about ghost hearts with Dr. Doris Taylor's really exciting research and others. And I think that, they say that tissue engineering is moving forward to whole organ synthesis at an unparalleled pace. I think, again, another really exciting opportunity to expand the donor pool through that. So let's look at the ultimate question, right? Should perfusionists be involved in organ recovery? I think the answer is yes. Whether you're a clinical perfusionist, you're in industry, or even a perfusionist scientist, I think this really fits within our scope of practice. And with that, the board has also, made in 2020 significant changes to realize and recognize the increasing improvements of perfusionists within these realms of care. And they did update it so that you can get your primary cases utilizing ex vivo organ perfusion. I reached out to them earlier this week, and they are working on really exciting talks about NRP as well. I think the current guideline for those cases is to also fit within this category. So in summary, I don't know if you've heard of a guy named Steve Jobs, but he says that innovation is the ability to see change as an opportunity, but not a threat. As you can see in the illustration here, we have many opportunities to increase the donor pool, whether it's through innovations in technology or medicine. Overall, perfusionists can play a vital role in their success. Thank you, and I'll take questions.